Okay, thank you very much, Tony. I'm now going to do a similar job for chronic low back pain as I did for osteoarthritis earlier on. Again, this is part of a wider review, and I'm going to show you some parts of it. Again, Grunenthal made available trial data from studies up to the end of 2014. There were 4 randomized trials, 2 cohorts, over 2,000 patients. Again, we had all the scores, and again, what I'm going to show you is unpublished data from ongoing analyses. And again, I'm going to concentrate on the issue of outcomes. I'm going to go a little bit further, but first let's start with outcomes. And the interesting thing for me is that we have so, frankly, little evidence from individual patient type analyses on different chronic pain conditions that we set out with no idea as to whether or not they were going to be the same or different one from another. Well, here we go, looking again at the link between percentage reduction in pain intensity over baseline during the course of a trial compared with the proportion of people who are having low pain state at the end of the trial. And you can see it's highly correlated. So if you have more than 50% pain reduction, you will have a low pain score at the end of the trial, and if not, not. Similarly, if you have a low pain score at the end of the trial, you're very likely to rate your overall impression of change as very much or much improved, and if not, not. Similarly, and again, telling you that we use a very conservative baseline observation carried forward if any patient withdraws for any reason in these studies. Similarly, if you're a non-responder, that is, you're getting less than 15% pain intensity reduction, by and large, you will end up with a low pain score. And by and large, as you can see, apart from a few excursions into lower pain states, most of these patients have got high pain scores over the whole course of the study. Raising the bar to 15 to 29%, you can see there's a gentle reduction in the first 3-week titration period, and then consistent scores thereafter. And if we raise the bar again to 30 to 49% of a baseline, again, this time a faster pain intensity reduction over the first 3 weeks, and then consistent results thereafter, with final pain scores in the range of about 3 to 6 out of 10. For those people who are unequivocal responders, who have a pain intensity reduction of more than 50%, just in exactly the same way as we saw with osteoarthritis, what we see is that the pain intensity has reduced at a rate of knots over the first 3 weeks. It's falling very rapidly from these initial very high pain intensity scores to modest pain intensity scores. And again, apart from 1 or 2 patients who have excursions into higher pain states, for almost all of these patients, what we're seeing is consistent results over the period of the study and in a low pain state over that period as well. So just as with osteoarthritis, we're able to say that actually, whether it's a change in pain, the final pain state, or a patient global impression of change, patients who have one of these outcomes will tend to have the other 2 as well, so that the particular outcome that you choose at the end of a trial really doesn't matter very much. And that results for individual patients tend to set early in the study and then are consistent over the continuing period. So again, this raises the question as to whether or not you can have prediction rules of any form. And you can. These are different prediction rules from Ralph's prediction rules. Ralph is using his QST to predict who will respond. I'm using these analyses to predict who will not respond. And these are really interesting and complementary approaches to trying to get to the point of view of treating the right person right in the right way for the right period of time, which is really our goal. Now, you might think I'm showing you the same slides as I showed you before, because these could fit one onto the other perfectly, but they're not. This is for low back pain. The others were for osteoarthritis. And those of you who could have got up early yesterday morning and seen my talk then, you would have seen an almost identical result for fibromyalgia. So basically, People who are non-responders, in the sense that they have less than 30% pain intensity reduction at week 6, after they've been given a good trial of tapentadol, are non-responders at the end of the trial. Previously, it was 91%. This is 89%. I think those are pretty close one to another. But in this particular case, what I'm going to do for chronic low back pain is to go further and link the changes that we see in terms of pain to those in other outcomes as well. So here, for example, we're rating for tapentadol the 1-year QALY gain extrapolated from the trial to the pain intensity reduction at the end of the trial. So going from left to right, we're getting better pain relief, and going from bottom to top, we're getting better quality of life. And these sorts of changes are really quite large in quality of life scales, which go from 0 to 1. And one can drill down with these individual patient analyses to individual questions on short form 36 or other questionnaires. So you could ask, for example, whether patients feel they have cut down on the amount of time they've spent on work or other activities in the past week, an important measure of function. Now, what you're seeing here is in light blue the result for baseline, in dark blue the result at the end of the trial, and again going from left to right, from those who had no pain intensity reduction to those with more than 50% pain intensity reduction. And you can see that at baseline all of them are the same. About 70% of people were cutting down, but that's dropped to about 30% for those people who had more than 50% pain intensity reduction. Have you had difficulty performing the work or other activities in the past week? It's very, very high, 80 to 90% at the beginning of the trial. But for those people who had more than 50% pain reduction, it's only 40%. During the past week, how much did pain interfere with your normal work? This is on a score there of 1 to 5, where 1 is not at all, up to extremely. And you can see at the beginning of the studies, we're in a position where people are responding that their pain interfered with their normal work moderately or quite a bit. And indeed, if they had little pain relief, it was much the same afterwards. But for those who had a very large degree of pain relief, more than 50% pain intensity reduction, we've gone from quite a bit to a little bit. And that is a very important additional benefit, which is very consistent with what we've seen in other areas of pain relief as well. So pain is important, and it's the primacy of pain. So if I can summarize what I've just shown you in chronic low back pain, I can say, just as I said with osteoarthritis, that the final pain intensity, the pain intensity reduction, and the PGIC are all closely correlated, that response, in this particular case to tapentadol, is consistent, well, you see it with other therapies as well. Patients tend to respond early and then continue with that level of response set during titration period with little change thereafter. Moreover, we can go further and suggest a stopping rule whereby failure to achieve more than 30% pain intensity reduction after 6 weeks, that's giving the patient a titration and a decent trial of the drug thereafter, it's a signal to discontinue treatment and try another one. As I've said, all of this is also to do with tapentadol, but it affects all the other treatments as well. But importantly, for chronic low back pain, response is also associated with improvements in quality of life, in function, and ability to work and look after one's family. Those are really important outcomes to take home. So thank you very much indeed.